Hello, my name is Behfar Ehdaie. I'm an assistant attending at Memorial Sloan Kettering, and it's my pleasure to present transperineal biopsy and classification of risk using novel Gleason pattern quantification. These are my disclosures relevant to this talk. This talk will outline the role of Gleason pattern quantification on prostate cancer outcomes. I will first focus on the current role of quantification of Gleason pattern in cancer. Second, I will focus on the role of biopsy technique to improve risk classification. In this study, patients with biopsy-proven prostate cancer were evaluated for recurrence-free probability based on biochemical recurrence across multiple centers. Gleason pattern was divided into grade groups 1, 2, 3, 4, and 5. As this figure demonstrates, biopsy pathology primary Gleason grade is prognostic of disease recurrence after treatment. What we can see is patients can be divided as grade group 1 or low-risk cancer, or high-risk cancer as grade group 4 or 5. Grade group 2 and 3 represent a heterogeneous group of patients and also represent intermediate risk disease. This is the focus of my talk today. We first evaluated the role of total Gleason pattern 4 and other quantifications of Gleason pattern across patients who underwent radical prostatectomy with grade group 2 prostate cancer at Memorial Sloan Kettering Cancer Center. We asked whether outcomes related to adverse pathology were associated with biopsy pathology across various quantification methods of Gleason pattern 4. We evaluated the total millimeters of pattern 4 across all biopsy cores, the highest percentage in a single core, the highest millimeters in a single core, and then reviewed those results across multiple predictive models to determine the best quantification method. As you can see from this figure, that the probability of adverse pathology after radical prostatectomy increases proportionally with every increased millimeter of total length of Gleason pattern 4. The shaded gray area represents the frequency of the total length of Gleason 4 in our cohort studied. We determined the total length of Gleason pattern 4 across all biopsy cores best predicts risk of adverse pathology post-radical prostatectomy compared to overall percentage or the maximum percentage of pattern 4 in a single core. This makes sense given there's variability in the percentage of pattern 4 based on the total length of tissue on each biopsy core. We evaluated both this in a decision curve analysis on the left and a multivariable model on the right. As we can see, the base model plus total length of Gleason pattern 4 across multiple thresholds of probability for adverse pathology after radical prostatectomy is better for predicting these outcomes compared to the various techniques demonstrated. In this other study from the University of Michigan, in which they evaluated Gleason pattern 4% in patients after radical prostatectomy and evaluated both adverse pathology and biochemical recurrence, they noted that the total percentage of Gleason pattern 4 is associated with rising PSA after surgery. Importantly, they did not evaluate total millimeters of cancer, but their study is consistent and the results are consistent with our data suggesting that Gleason pattern 4 quantification methods are associated with outcomes after radical prostatectomy for patients with intermediate risk prostate cancer. In this data, we subsequently evaluated biochemical recurrence in our data set of patients with grade group 2 prostate cancer who underwent radical prostatectomy. Again, we demonstrate that the total length and percentage of pattern 4 is associated with 3-year biochemical recurrence defined as a PSA greater than 0.2 after radical prostatectomy among patients with grade group 2 prostate cancer. All 4 figures represent different methods to quantify pattern 4. We focused on the total length of Gleason pattern 4 on biopsy, and we can see in the figure on the bottom left that as the total length of Gleason pattern 4 increase per millimeter, it is associated with a proportional risk in 3-year freedom from biochemical recurrence. The gray shaded area again represents the quantification of total length of pattern 4 in our cohort. As we can see, the majority of patients had a total length of Gleason pattern 4 of less than 2 millimeters with grade group 2 prostate cancer. Second, we need to incorporate multiparametric imaging and tracking software to improve the detection of higher grade prostate cancer. This has occurred over the past decade with various methods to undergo mpMRI targeted biopsies. In this device, defined by the Coela system, a 3D ultrasound probe is inserted an image is obtained of the prostate, and this is correlated with MRI images, and these two images with 3D ultrasound are laid upon one another. And an organ-based tracking software is used to recalculate the location and size of the prostate based on the current patient being treated. Finally, these biopsy cores are saved in the system for later tracking. So this enables a systematic way to ascertain prostate biopsy using an MR-targeted technique. And we know from data that we have presented and published that MR-targeted prostate biopsy improves detection of higher-grade disease for men on active surveillance. In this study, we evaluated PIRADS score, defined by an MRI score greater than 3, and we looked at both an MRI-targeted biopsy plus a systematic biopsy or MR-targeted biopsy alone. And we can see when this data was simulated across thousands of biopsies, that the number of missed biopsies was the least when MRI target plus systematic biopsies were incorporated. This occurred even if the threshold for biopsy was an MRI score of 3 or an MRI score of 4 or greater. Using MRI is important. In this study, we evaluated that on patients on active surveillance, that approximately 22% of patients experienced an increase in their PIRADS score compared to their surveillance MRI. Again, suggesting that patients do experience changes in imaging that can be correlated with outcomes. And as we increase biopsies, and with an increased risk of sepsis associated with biopsies, with increasing antibiotic resistance with microorganisms, there has been a shift to transperineal biopsy. Transperineal biopsy enables a systematic course to be taken in a grid-like fashion that can be standardized across physicians, hospitals, and caretakers. In this study, the authors evaluated transperineal biopsy versus trans-rectal biopsy across a cohort retrospectively collected of men on active surveillance. They demonstrate that using a transperineal biopsy, patients were reclassified and higher grade cancer was detected at a higher rate compared to trans-rectal biopsy. This is an important finding given that any classification system of pattern 4 based on length would require detection of higher grade disease at a higher incidence and also quantification to be standardized. This suggests that transperineal biopsy may provide us a standardized technique to achieve better sampling and subsequently classification of risk. And a technology that is capable of transitioning from transrectal to transperineal prostate biopsy is key. This is another demonstration, the Coelis Trinity device, that has incorporated a transrectal and 3D transperineal probe, which allows an easy access through the perineum of the prostate using a single grid. Importantly, the number of targeted cores needed to achieve optimal sampling is dependent on the region of interest on MRI or PIRADS score radiology interpretation. We demonstrated that a minimum of 2 cores is needed and upwards of 3 cores based on PIRADS 3 or higher prostate cancer to achieve the maximum amount of higher grade detection in patients. Therefore, if we will evaluate quantification of total Gleason pattern 4 standardization of biopsy technique, both in a grid fashion standardized with a transperineal approach and the number of targeted cores taken from each region of interest or MRI, will allow homogeneity in calculating the total millimeters or length of pattern 4 across all biopsy cores. So in conclusion, incorporation of total biopsy length Gleason pattern 4 improves risk classification for men with grade group 2 and grade group 3 prostate cancer. An implication of these data is utilizing total biopsy Gleason pattern 4 length to select patients for active surveillance and develop triggers to recommend subsequent treatment. Systematic biopsy cores added to MR-targeted biopsy improves overall detection of higher grade cancer. A seamless transition from transrectal to transperineal biopsy enables a template-based biopsy to standardize sampling for risk stratification. Thank you very much.